Hello everybody, my name is Steve Jones. I lived with idiopathic pulmonary fibrosis for 8 years before having a lung transplant a few years ago. The first of these is the slow pace of drug development. Patients urgently want therapies that will stop pulmonary fibrosis, stop it in its tracks, and will enable us ultimately to rebuild damaged lungs. There have been no new therapies now for 10 years, and while the two existing antifibrotics do their job, as we know, they have serious side effects. And while we're encouraged by the large number of clinical trials ongoing, 40 at my last count, patients are frustrated at how long it takes to get new products into use and are disappointed that 3 very promising trials failed in the last 3 years. A second area of concern is timely and accurate diagnosis. It's currently taking over a year to be diagnosed with pulmonary fibrosis in many European countries. This is completely unacceptable for a disease with a worse prognosis than most common cancers and a life expectancy of only 3 to 7 years. Speeding up diagnosis and treatment is a high priority for patients. And why can't we have a time-bound pathway to diagnosis and treatment in the same way that cancer patients do in most countries? The third area of concern is integrated care. Patients in most European countries are generally satisfied with the medical care that they receive at specialist centres once they get there, but they're very dissatisfied with the difficulties they face in accessing pulmonary rehabilitation and psychological support, in some cases accessing supplementary oxygen, and in many countries, problems in planning of end-of-life care. All of these seriously impact on the quality of life of patients living with pulmonary fibrosis. We need an integrated, transparent system of care which brings together the medical care of the specialist centre with these other areas of care. Generative artificial intelligence is starting to be used in drug discovery for IPF, and this could save 2 to 3 years on the current production development period of about 10 years. All AI is used already quite extensively, increasingly in the interpretation of HRCTs, which is leading to faster and more accurate diagnosis. And e-breath technologies hold great potential. Remote monitoring of patients for blood pressure, spirometry, oxygen saturation, exercise tolerance, using an app on a smartphone is proving very popular and reducing the number of visits that patients need to pay to hospital, and also reducing the costs to healthcare systems of treatment. While most patients are happy to do some remote monitoring at home and have some virtual consultations, they also want to be able to see their healthcare professionals regularly and when they need to. Secondly, as we know, not all patients have equal access to the internet, and even those with access to the internet don't know how or don't want to use it. There's a lot that can be done now to speed up clinical trials by pharma companies, regulators, and patient organizations. These things can and should be done, and they don't necessarily need innovative technologies. For example, increasing the number of sites for clinical trials in different countries by companies, regulators, patients working together, doctors, to make that possible. Finally, no matter how good your new technologies, many of the problems currently facing healthcare systems are an institutional or financial nature. To address these and put pressure on healthcare systems to treat pulmonary fibrosis patients better, we need to work together across the PF community. Patients and healthcare doctors and practitioners and doctors working together to bring about change. Thanks very much.